My name is Edmund Messina. I'm a neurologist and a headache specialist, and I run the Michigan Headache Clinic in East Lansing, Michigan. We're a private clinic. We're not part of any hospital or corporation or anything. We're fiercely independent. So I'm not. Everything I say here is not being funded by anybody except nobody. Okay. We're going to talk about comorbidities. Now, a comorbidity is a condition that occurs with another condition. In the situation with migraine, comorbidities, very common ones exist, including mood problems or sleep disorders or other things. And I'm going to mention these things. These are important because when you have a migraine problem, a lot of other conditions will interfere with your diagnosis, but also will interfere with the things that might make you better. Some comorbidities or other conditions will interfere with the medicines that might work in migraine, or might cause more headaches, or might interact with the medicines in such a way that they're maybe even toxic. Some nutrients or so-called supplements will sometimes actually cause regular medications to become toxic or not work. So the type of comorbidities I want to talk about, there are many of them, and I'm going to hit upon just the main areas, and I'm going to hope that your questions are going to help me with deciding what else I want to say. Remember, when you see someone about your headache disorder, the most important thing is to be sure that someone is going to spend the time to talk to you and take you seriously. Just because you have symptoms of anxiety doesn't mean that that's why you have headaches. People who have anxiety disorders or depression, well, there's about a 30% overlap between migraine and mood disorders. About a third of all people, if not more, who have migraine, especially migraine with aura, tend to have the anxiety or depression problems. Migraine with aura seems to put us, and I personally get migraine with aura. I've had them since I was in the third grade. I thought everybody was coloring with their crayons and everything turned purple and then you'd throw up. I thought that was normal. Apparently it isn't. But that's when kids get migraine, a lot of them will get these other incidental so-called Alice in Wonderland symptoms. But people with migraine, especially with aura, are more likely to get a lot of the complications and comorbidities. Now, anxiety and depression are very common in migraine patients. And we find it sometimes very useful to plan our treatment strategy to incorporate the package of things that a person has problems with. Now, I mentioned anxiety and depression. Insomnia is another one of those things which is very common in the migraine population. So people with migraine who have anxiety, yes, anxiety can exist by itself, and it does. Anxiety with migraine is a special problem because many people who have a baseline migraine problem to begin with may have more attacks if they're more anxious. We all have had the experience where we have a migraine triggered by a stressful situation, confrontation, or when the universe gets really bad on you certain days and you get more headaches. Migraine people are susceptible to this, and this comorbidity of anxiety. Stress will trigger a headache, yeah, and sudden stopping of stress, like the exams are finalized, teachers got their grades turned in, whatever, and then you get a headache. These happen too. But the anxiety and migraine, it's important to be sure that your treating practitioner knows that you have all of these problems. A good medical evaluation has to ask about anxiety, depression, sleep disorders, other medical problems. A good first visit history really should take an hour or two if you're doing it right, and if you're going to find all the things that will trigger or interfere with your care of that patient. Now, the anxiety patients, there are many medicines that work against anxiety which won't touch migraine. The pure SSRI, serotonin reuptake inhibitor drugs like Prozac and Celexa and such, they work very well. They're not really much in the way of migraine meds unless they suppress the anxiety enough that you have less triggers for your migraine. So it is with the antidepressants. The pure norepinephrine type antidepressants such as Wellbutrin, they work very well in depression, but they don't really they're not really first-class migraine preventative agents. We have a lot of good luck with the combination drugs, which have serotonin reuptake and norepinephrine reuptake properties. Now, again, I'm throwing these terms at you. There are certain chemicals in the brain which have to do with mood, but also have to do with migraine. The serotonin receptors in the brain, for example, are hit by Imitrex or Maxalt or any of the triptan drugs. They actually hit that receptor, the 5-HT1 B and D receptor. The D is the one we really want to target. The serotonin is cut loose during a migraine. There's a very high amount of serotonin byproducts in the urine after a migraine attack, for example. So these things shift around, and in the brainstem, if we can find a way to block or enhance the effect of certain of these chemicals, we can control the migraine. Now, in order to treat anxiety and depression and migraine in the same breath or same med, we use combination drugs, like I said. One of them is venlafaxine, which was marketed as Effexor. Now it's a generic drug, or Cymbalta, which is duloxetine, which was marketed as Cymbalta. Both of these drugs, especially the venlafaxine, have dual properties. They're not shotguns with broad effect like the older, amitriptyline class drugs. Amitriptyline, by the way, came out in 1951. These newer drugs, these combination drugs, are like two rifles side by side, not a big blast of a shotgun. So they're very precise, and the dosing is very, very useful. When we use venlafaxine, we often get really good results with the migraines and also with the anxiety or depression, especially the anxiety, because these medications will hit both problems. The interesting part, and a lot of the primary docs may not know this unless they're familiar with the venlafaxine, in the lower doses, venlafaxine acts like an SSRI, like a Prozac kind of drug. And as the dosing goes up and you get near 150 milligrams a day, the second type of chemical action kicks in, the norepinephrine. And so a lot of times when we first start the med, the lower doses of the Effexor don't seem to be working on migraine, but they're working on the anxiety, which people already are benefiting from. But once you hit that 150 mark or higher, and often we will go higher, the migraine starts melting down and going down. Again, when you're talking to your caregiver, your physician, your PA, your nurse practitioner, you got to go in there armed with knowledge about how frequent your headaches really are. And we have found in our practice the simplest way to track the headaches is a piece of paper with 31 lines on it. And because all we really need to know is, when did you have a headache? What did you do to treat it? How bad was it? And if a person has periods, when did the periods stop and start? And the perfect headache, really the perfect headache calendar is a piece of paper with 31 lines on it. Because at a glance, I could look at it and I could see how many days in a row headaches are coming on. Oh, look, they're all grouped around menses, around periods. It's an excellent way to do it. Some of these apps online, I still haven't found one that I like, and I've been watching them since they first had apps. They don't seem to be as practical to us as when a person walks in the door with this silly little piece of paper and we can see when we have the blank spots, when we have the grouping of headaches. It's extremely helpful. And when you go in to see the person who's treating you, they should know how often the headaches really are and what did you do and what worked. And it's helpful if you notice an obvious trigger, note it on the headache diary. The idea of food triggers is pretty controversial. The so-called headache diet really never panned out since the 70s. We all know, and again, as a migraine person, I can say, I know there's certain foods that if I eat them, I'll probably get a headache. But usually I have to eat a lot of it. It's dose related. As a little kid, I remember if I had a half a glass of chocolate milk, no problem, a whole glass, headache. Many people notice their food triggers. There are papers being published now telling you there's no such thing as a food trigger, but these are papers based on large populations of people. In a given individual, like most research, given individuals have very different outcomes and different results than these big meta-analyses, which I don't take a lot of stock in. All right, so comorbidities, again, here we are. We talked about anxiety and headaches and depression now. The depression is a special problem as well. The problem with depression is when people are truly depressed, they get very nihilistic about the fact that they'll ever get better. A pessimism comes with depression in many people. In fact, the irony, it's a sad irony, but people will actually feel depressed, and because they're depressed, they're convinced that no one can ever help them, so they don't seek help. Just like people with anxiety who have social anxiety, these people will be too anxious to go seek help with a therapist because they're too nervous to go and see someone because it's a social interaction. So rolling it back to the migraine world, we meet someone who has migraine, we ask a lot of questions about their anxiety and their depression. And interestingly, we often see a pattern. The more you ask, the more you talk to people, the more you find out. There might be some people who only have problems with their migraines when they're traveling, and it may not be anything other than the fact that it's stressful for them, or they're away from home. Some people, sadly, when they're home, they have more migraines because they don't get along with their spouse. It's very important to really spill everything you know when you're talking to your treating person, because these may have a lot to do with the kind of strategy that can help you. So, all right, so anxiety, depression, migraine, they commonly occur together. But there are other things that we have to be aware of, and people who have migraine, sometimes when they don't get better, it might be that they don't really have migraine. And I want to say a couple of things about some mimics. A mimic is a condition that acts like the condition you think you have, but maybe it's not that. For example, a lot of people have spontaneous low spinal fluid pressure headaches. Well, a lot in my world, because I see a lot of them, but I guess they're relatively rare. Some people, my computer screen light went out there. All right. Some people will stand up after a spinal tap and get a headache. They'll lie down, the headache goes away. Those post-spinal headaches, those are easy to spot because you just had a spinal tap for whatever reason. And usually within a week or two, they're gone no matter what you do, or if someone does a blood patch, it'll take it away. Those are not a big problem. Those people never end up in the clutches of a headache clinic. But some people have a spinal fluid leak. And when they first have this happen, somewhere along their spine, it could be because of a disc or some degenerative changes in their back, the lining around the spinal canal, which carries spinal fluid, starts to ooze a little bit of fluid into the tissues. And, you don't see it, like if you sit down, you don't see it on the chair, but it goes into the tissue. And the brain is supposed to be floating in spinal fluid. And when you have a leak, you have less volume of that spinal fluid, and the brain kind of tugs on its support structures, and it produces the pain. These people, they lie down, their headache gets better. They sit up, walk around, their headache gets worse. And if it persists more than a few weeks, it's important to be evaluated. But when you talk to your physician or PA or NP, make sure they know that you have a positional difference in your headaches, because that's a totally different diagnosis, and sometimes there's a cure, and it doesn't have to be migraine. Of course, migraine people can have anything else happen to them too, so it's very important that they ask you good questions and that you really make it clear over time how these things have come to pass. Another type of headache which you should be aware of is a condition which is not real common, but it's not that rare. We have several in our practice, and we are always looking for this. And this is called Hemicrania Continua. It's one of the headaches that I think in the past we thought that was more rare than it really is. People with Hemicrania Continua, they have a headache that feels like a migraine. It's on half their head, but it doesn't go away. It doesn't come and go like a migraine might. It's there all the time, and it can flare up for a few hours at a time, and sometimes it even feels like a migraine. These people, usually on the side of their pain, will end up with a droopy eyelid or a runny nose or a runny eye. And those are called autonomic symptoms. And Hemicrania Continua people do not respond to any of the migraine medications. And some people are just driven mad by these headaches. They have them for, sometimes years, and no one ever seems to figure them out. Then along comes someone who asks them the right questions and hears about the type of pain it is, never goes away, flares up for a few hours at a time, excruciating maybe during those flare-ups, but never gone. And they have this funny stuff with their eye and their nose. It's always on the same side. They might even be light sensitive in one eye, but not both. Or migraine, of course, as you know, both eyes are sensitive to light in most people. Now these people, if the doc knows the diagnosis, we'll give them a medicine called indomethacin. And if they get better, I mean, literally stop dramatically within a few days, that's the diagnosis. And it's called Hemicrania Continua. And the treatment plan, of course, has to go beyond just the Indocin. You can't take that forever. It'll burn a hole in your stomach. But again, it boils down to the history you give the person that's taking care of you, and that they need to spend the time and really ask you all these questions. It's like anything in medicine, the only successful outcomes are based on getting a proper diagnosis to start with. So remember, if you're having that one-sided headache, and even if you don't get the eye symptoms like the runny eye, the stuffy nose, droopy eyelid, if you're agitated and pacing the floor when the headache gets bad, that's not a migraine. Migraine people don't do that. Migraine people want to quietly hide in the corner and die in silence. Very different from the hemicrania patients. Some of them almost act like they have cluster, and cluster's a totally different kind of headache. But think in terms of, if you're not getting better, be sure the person taking care of you knows about these conditions at least, because this could change everything. Now, other comorbidities that we worry about are things which can interfere. For example, if a person has cardiac disease, we know they can't take the triptan drugs. Marvelous drugs, the triptans, and for the moment, these are the best we have to offer right now to put out a headache. But we can't give them to people who have cardiac disease or peripheral vascular disease, or anyone who had a stroke. They cannot take triptans, and triptans would be sumatriptan, rizatriptan, all of the 7 triptans that have been out now for a number of years. The big thing about that is when people have certain types of migraine, they also should not take triptans. Now, there's a condition known as hemiplegic migraine, where it acts like a stroke, where half of your body will become weak. Hemiplegic migraines are not as rare as we once thought they were. I don't think a day goes by I don't see somebody with a hemiplegic migraine in our clinic. Hemiplegic migraines, a patient will get a migraine with an aura. That's a requirement to fit the category of hemiplegic migraine. But then there's motor loss. There's loss of strength. A person might feel their face is drooping. On the same side, they might notice the arm is getting heavier, weaker. Maybe the leg will buckle. And these usually develop gradually, not suddenly. Now, many people with hemiplegic migraine who first experience it and go to an emergency room might be diagnosed as having a stroke or a TIA, which I guess the safest thing is to assume the worst and take precaution when they evaluate you. But the hemiplegic migraines develop very slowly. A stroke, bang, there you have the weakness, where hemiplegic migraines develop over many minutes. And the weakness might last for days in some people. Now, number one, it's important to have that diagnosis, and the person treating you has to be sure that they've looked at things that can cause strokes. Even in a young person, young women with migraine with aura, even 25 years old, could have a stroke. That can happen in migraine. So with hemiplegic migraine, the take-home message, of course, is you should not use constricting drugs, which are the triptans. There's controversy in our literature, and there are certain brave physicians out there. To me, brave is when you do something that's dangerous to you, not to your patient. But certain people who will actually give patients these triptans, and they claim they don't make them any worse. I would not do that. Now, the hemiplegic migraine I mentioned. Now, another kind of migraine which acts different enough that you have to be careful not to use triptans, and those are the migraines with brainstem aura. We used to call these basilar migraines. And this is when a person has a migraine with an aura. Now, the aura officially is usually visual or sensory tingling. Visual auras are usually either a spot in your vision that tends to start in the middle, usually in the middle, could be on the side, and marches across your vision. And eventually, maybe within half an hour, you start getting a severe headache. And that's the migraine with aura. A relatively small percentage of all migraine people get auras. But when people have a basilar type migraine or brainstem aura migraine, they will have the aura, as I mentioned, but then they'll have double vision, or they'll have a tunnel vision. They'll have intense dizziness, vertigo, slurred speech, and such things. And those people have to be carefully evaluated. Again, our job is to be sure it's not due to something more severe. And of course, once we have that diagnosis, I belong to that group of people that would not give a triptan to those people because the belief is maybe it can cause a stroke. We don't know, and it probably doesn't, but we don't dare to use these medicines right now. There are some new meds being developed right now. They're called the Gepant set of meds, Gepant. They almost had one out about 5 years ago, and it didn't make it through phase 3 testing, and it was causing liver failure. So we've had a bad taste on that one, but there's a newer one that's making its way through the FDA right now. Don't know if it'll make it through. So far, it sounds like it's safe, but we don't know that yet. But that class of med can be used in anybody with stroke, heart disease, hemiplegic, basilar type migraines, and we'll be able to hopefully use it in those patients because so many of our patients can't use the triptans because of that, because they have comorbid vascular disease, stroke type problems, heart disease, peripheral vascular disease. So that'll be an interesting development. Stay tuned in the next few months. I think the first one of that group is going to probably make it through the FDA, we think. I'm not going to jump out and use it, needless to say. I'm going to wait for someone else to use it. But those are the important comorbidities. Now, I just want you to know that that a lot of things can coexist with migraine. Many people with migraine, it's very common to see people have neck pain with their migraines. Now, there's the perpetrator and the victim. Some people believe that the neck is the culprit for every migraine that exists. And we have a lot of solid data that shows us that migraine itself radiates pain to the neck. It's when you're... That screen keeps going on and off. We know that when you're having a pretty good migraine, you'll often have posterior pain, in the back of the head, up the top of the neck. The nerves that supply the upper neck muscles and the back of the head mingle with the nerves that are the ones that come in above your forehead, around the eyes, the trigeminal system. That whole system mingles together when the battle for migraine is being fought. So you'll feel you have pain in all these locations. And but there is a subset of people who have what's called cervicogenic headache. These are headaches that are intense. They don't have to be, but usually they're pretty bad, and they're provoked by turning the head or touching the back of the head. And these headaches are called cervicogenic. They just always occur only on one side in the back of the head. And usually you can provoke them by pressing on the neck or turning the head. And these often do very well with physical therapy or occipital nerve blocks. The neck is usually not the cause of most headaches, but it's certainly a common accompaniment. And most people with migraine, if you ask them, they'll tell you their neck hurts at some time or another, or their neck is stiff. It's not that unusual to hear these things. So that's a common one. Fibromyalgia is a common comorbidity to migraine. There's a huge overlap in people who have fibro and people who have migraine. And it seems weird at first. You say, well, that's a muscle problem and migraine is a brain problem. But in reality, they have a lot in common. Migraine is because the brain is very sensitized. The ability of the brain to handle pain signals, there's a mismatch between the part of the brain that suppresses pain and the part of the brain that makes pain. And people with fibromyalgia have a similar problem. Now, migraine people and also chronic tension type headache people have what's called allodynia. Now, allodynia, it's another term we're using a lot of that these days in our explanations of migraine. Allodynia is when you touch an area that shouldn't be hurting, but it does. I mean, it's typical after a bad migraine. Your hair hurts, and it sounds crazy to people who don't have migraines. It hurts to comb your hair. You touch your scalp. It's painful. That's allodynia. It's when a non-painful stimulus produces pain. It's like if you have a really bad sunburn and someone grabs your arm. That normally wouldn't be painful, but it is when you have that problem. So allodynia, it could be in the hair, it could be on the forehead. I remember one patient told me that if he breathed in too deeply, the air passing through his nasal passages was painful. That was allodynia. Now, here's the handy hint, which is useful. If you're going to treat a migraine and you're going to use a triptan, use it before you get allodynia. By the time allodynia sets in, it means you've had a tremendous sensitization of the pain system, and the triptans may not work at that stage. Sometimes they make it worse, especially in the early days of sumatriptan, when the only way we gave it was by injection. If someone waited too long to treat their migraine and they hit it with that injection, they would have a screaming worsening of their pain. So that would be allodynia. Now, chronic tension type people get the same thing. They'll have tenderness of their scalp muscles, and these are things to look out for. It's a sign of turning chronic sometimes too. So it's an associated symptom. It's not really a comorbidity. But what I was driving at with the fibromyalgia people, and probably a good percentage of you watching this probably have fibromyalgia symptoms, the basis for the pain is based on hypersensitization of the nervous system. And often medicines that work in migraine can work in fibromyalgia and vice versa. And that's what makes it interesting. Some of the, for example, the tricyclic antidepressants like amitriptyline, which we don't use much anymore because it's so sedating, or nortriptyline, can work in both conditions. People use gabapentin or pregabalin, which would be Neurontin or Lyrica. Sometimes it works in migraine. It's not officially a migraine preventative, but many people have found that it works, and of course it works in fibro. So these are things that could be connected. We also know that people who do auto-relaxation techniques, biofeedback, progressive relaxation, there are many, many breathing and stress managing exercises. Those aren't just to reduce stress. A lot of times they will reduce the pain because they act upon the part of the brain that can suppress pain signals coming in. And these can be very useful. In kids especially, these can be very useful techniques if you can convince somebody to give it a try. And there's no magic to it either. It's just simple relaxation. But the technique is there. They sell devices you can buy online, for biofeedback. There are some cheap ones which work well for galvanic skin response, on your fingertips. There are the muscle ones, temperature ones. Those can work, although usually most people don't need them. They can get away pretty much with the breathing relaxing exercises, and we posted some of those on our website even. They're simple, and everybody who sees a therapist who talks about stress is going to give you a version of this, and they tend to work. But those are the musculoskeletal comorbidities are very common. Now, a lot of people with migraine have pain in other areas, and a lot of times they're being treated with painkillers. Especially inappropriate would be chronic opioids being used for low back pain. It's never been the treatment of choice for low back pain, but unfortunately, it's very commonly being done. Migraine people can develop medication overuse headache, or so-called, what we used to call rebound headache. And medication overuse headache is when you use a certain medication too often, and it essentially undermines the brain's ability to handle pain signals. It messes with the system inside, which suppresses pain. Butalbital, which is the active ingredient in Furanol and Furacet, is one. Current stats show that maybe more than 4 days a month even could be associated with an increased risk of rebound headache. If you're using an anti-inflammatory of any type, the nonsteroidals, 15 days a month or more will probably lead you towards more chronic headaches. Opioids, more than 9 days a month. Triptans, more than 9 days a month. These are all ways you can actually produce worsening of your headaches, because the comorbidities are things we have to think about. Now, I'm going to mention sleep. Let me look down at my timer here. Oh, yeah, we're good. Sleep, very important. Insomnia is common in migraine. Sleep deprivation is a very common trigger to migraine. And here's where it gets difficult. Some people, not many, but some people will find they could sleep off a migraine. But if they do that and it's late enough in the day, they're probably not going to get to sleep that night. And that's going to provoke the next headache. These are big problems. Chronic addicting sleeping medications are never a good idea either. So here comes insomnia and here comes migraine. There are a lot of very good ways to treat insomnia without doping yourself up. The VA commissioned Stanford University to create a sleep app that runs on the iPhone or any smartphone. It's called CBT-I Coach. CBT means cognitive behavioral therapy, and -I for insomnia. So CBT-I Coach. It's free. Download it. Be careful when you go to find it, because there are some that sound like it and they charge for it. This is free, and it's written by the very smart people over at Stanford. CBT-I Coach has about the same success rate as sleeping pills in getting you to manage your sleep. And sleep is an important deal. Now, we ask a careful sleep history of all of our patients. It's not that rare to see sleep apnea. And sleep apnea is when you stop breathing or you underbreathe more than 5 times a minute. People with, or an hour, people with sleep apnea will be usually loud snorers. They tend to be overweight, but not always. They will always wake up in the morning not refreshed. They'll fall asleep all over the place during the day, get into car accidents, get in trouble at work, falling asleep on their desk. The most extreme, that's what they will be. Less severe sleep apnea people are sleepy. They're able to kind of mask it at work, but they just never wake up refreshed. And they're told by their bedmates that they snore really loudly. The term disruptive snoring is an extreme. Disruptive snoring means you could be outside of the room with the door closed and still hear them snore. Sleep apnea is diagnosed by doing a nocturnal polysomnogram, a nighttime sleep study, all-night sleep study. This will show whether or not you're moving air, whether or not you have an obstruction. Usually it's in the back of the throat where the obstruction is. When they buy those little things for their nose that they advertise on TV, that has nothing to do with sleep apnea. Sleep apnea people have more headaches. They retain CO2. They wake up with headaches often. Unless you treat it, you're going to be in trouble. It increases the risk of heart disease. It actually causes weight gain. If untreated apnea causes weight gain, and weight gain worsens the apnea. Of interest also, one of the risk factors for going from episodic migraine to chronic migraine is obesity. And another risk factor, whether you have apnea or not, is snoring. And it's got something to do with back pressure. So these are things you got to be aware of when you're talking to your treating person, because untreated sleep apnea, big problem. Now some people wake up, this is kind of cute, some people just wake up, bad headache every morning, they start breathing air again, move around a little bit, and then their headache seems to let up a bit. A lot of times we ask these people, are they sleeping with their head under the covers, totally? And these are called turtle headaches. I just like the name. Because their head is under the covers completely, they're breathing and rebreathing their own CO2, which gives them headaches.